Hello and welcome to this Doc Talk educational program focusing on the clinical utility of angiogenesis inhibitors in metastatic colorectal cancer. I'm Dr. Jim Epstein, and joining me for this program are Dr. Scott Kopetz from the MD Anderson Cancer Center, Dr. Axel Grothe from the Mayo Clinic Rochester, and Dr. Jolene Hubbard, also from the Mayo Clinic Rochester. So we're going to divide this program into three separate sections. In this first section, Dr. Grothe is going to give us a review on the evolution of therapy for metastatic colorectal cancer over the past few decades, bringing us up to and giving us a sense of the standard of care up into 2012. Then Dr. Jolene Hubbard will look at the data and the clinical trials involved with monoclonal antibodies and targeting the vascular endothelial growth factor. And then finally, Dr. Scott Kopetz will look at VEGFR and the tyrosine kinase inhibitors and looking at targeting VEGFR as opposed to VEGF itself. Then in the second session, we're going to look at 4 representative clinical cases to try to give you an idea as to how the experts manage a patient through the full sequence of first, second, and third line therapy for metastatic colorectal cancer. And finally, in the third section, we are going to have a roundtable discussion of the type of questions that you undoubtedly will have in mind after these presentations. How do you manage patients? What do you do in case there's rapid progression? Do you go back and use frontline therapy again? When do you switch angiogenesis inhibitors? And we hope that you'll find that session very useful. So let's get started, and we're going to have Axel Grothe give us a sense of what the standard of care was prior to 2012. Axel?
Yeah, thanks, Jim. And it's important to keep in mind that 2012 really was a watershed in terms of new drug development, because we had seen new treatments emerge since then, which hadn't happened actually for many years. So when we summarize things from a medical oncology perspective, how do we treat metastatic colorectal cancer? We use drugs to keep patients alive. We're talking here about the palliative patient, not the potentially resectable patient. So our goal is really to utilize treatment options to extend the duration of patients' life, maintain their quality of life. And we utilize these agents, irinotecan, capecitabine, oxaliplatin, standard chemotherapy agents added or in conjunction with 5-FU, and kind of more modern agent, monoclonal antibodies against EGFR receptor, cetuximab, panitumumab, and bevacizumab. And using these agents in combination sequentially, we have improved median overall survival up to about 2 months in clinical studies. But we had a plateau in drug development from about 2004 to 2012, where the most important issue that actually came up was discovery that KRAS mutated tumors do not respond to EGFR receptor antibodies. So just to highlight and give a kind of a background, where are we right now, or where were we with our treatment paradigms for metastatic colorectal cancer? Number one, some patients actually can be cured with metastatic disease using an interdisciplinary approach, liver metastasis, organ-limited disease. In a palliative setting, FOLFOX equals Xelox equals FOLFIRI, and I think we all acknowledge that we really don't need to have another trial testing these combination chemotherapies head-to-head against each other. I personally do not use capecitabine irinotecan because of overlapping toxicity. Most patients tolerate a chemotherapy doublet, but not all patients need it, especially if you then add bevacizumab to a fluoropyrimidine, for instance. You'll see some data later today. This is a very active combination. When the biologics came about, we thought, this is going to revolutionize how we treat patients with metastatic disease, going to improve duration of life quite dramatically. We've seen improvements, but probably not as much as we wanted it to be. But I do believe we're on the verge of more individualized therapies based on molecular treatment patterns for patients. The concept of all 3 drugs, as illustrated on this slide here, indicates what we can achieve with chemotherapy overall when we expose patients to fluoropyrimidine, oxaliplatin, and irinotecan, either in combination or sequentially. And we've learned that when patients get exposed to all these 3 different drugs, they have maximum benefit. It doesn't really line up a certain sequence, but patients need access to all these agents. Now, the biologic agents until recently, until 2012, that had proof of efficacy in colorectal cancer were really monoclonal antibodies targeting the EGF receptor system, cetuximab, panitumumab, or VEGF with bevacizumab. This has changed. We're going beyond monoclonal antibodies nowadays, beyond 2012, and you'll hear a lot more about it later today. Let's talk about the efficacy we've seen with anti-EGF receptor therapy, cetuximab and panitumumab. We're targeting tumor cells directly. EGF receptor is a membrane-bound protein on the surface of tumor cells, and by inhibiting ligand binding and activation of this receptor, we were thinking of shutting down the downstream signaling cascades and the phenotypic properties of these cancer cells. Now, we've learned that if KRAS is mutated, meaning activated, whatever happens upstream, meaning targeting EGF receptor or with a monoclonal antibody, doesn't matter anymore, it doesn't work anymore. And about 40% of patients have KRAS mutations. As we know, this is very well established. Now, EGF receptor antibodies work quite well in a salvage therapy setting. In a later line setting, we have pretty convincing data for cetuximab and panitumumab. Here, data from the Canadian-Australian trial investigating cetuximab versus best supportive care in a palliative last line setting. And it's easy to see that in patients with KRAS wild-type tumors, duration of life was doubled and progression-free survival was doubled, whereas patients with KRAS mutant tumors did not obtain any benefit. Now, if we move the EGF receptor further, kind of earlier in lines of therapy, the pivotal trial is the CRYSTAL study, well-cited, a large trial, 1,200 patients, adding cetuximab in a randomized comparison to FOLFIRI. Progression-free survival was the primary endpoint, and the initial data showed, which were not KRAS adjusted, that the separation of these progression-free survival curves came very late, at about 40–50% of patients. Hazard ratio was not very convincing, p-value was barely positive, and the curves kept dancing around each other for some time, indicating there's a subgroup of patients that had no benefit. Again, this was not KRAS adjusted. We have learned later, of course, that only patients with KRAS wild-type tumors have a chance to benefit from cetuximab. So the later analysis now, as shown on this slide here, shows an earlier separation of the curves, progression-free survival, hazard ratio much more convincing, p-value much more positive, and actually the difference translated into a statistically significant overall survival, which is why one of the options in first-line therapy right now is using an EGF receptor antibody, cetuximab, with FOLFIRI. Now, where should we place the EGF receptor antibodies in our treatment sequence? And this slide illustrates in a kind of compositive way the data of the phase 3 trials that are available with EGF receptor antibodies, cetuximab and panitumumab. And bottom line is, the higher the bars above the zero line, the stronger the hazard ratio difference between EGF receptor antibody and no EGF receptor antibody is. And it's easy to see that from the earlier lines of therapy, adjuvant, first line, second line to salvage therapy, the later we utilize these agents, the more benefit in terms of hazard ratio we're obtaining. So in my clinical practice, I tend to use EGF receptor antibodies rather later than earlier because we can use them as salvage therapy. They maintain their efficacy. Now, the other antibody that we use in clinical practice is bevacizumab, an anti-VEGF antibody based on the pivotal data shown on this slide with IFL plus minus bevacizumab. That's almost 10 years old now, since Herb Hurwitz presented the data initially, showing benefit in terms of time-related endpoints, progression-free survival, a median overall survival, highly statistically significant. When we look at the PFS curve, you see that these curves separate early. There does not really appear to be a subgroup effect like we saw for cetuximab. Hazard ratio of 0.54, pretty strong, with a significant p-value and a median difference in progression-free survival of about 4 months. Now, IFL is a backbone which no one uses anymore, and we have standard chemotherapy regimens like FOLFIRI or FOLFOX or capecitabine oxaliplatin. And bevacizumab was widely used in conjunction with FOLFOX in first-line therapy even before we had data from this pivotal study, the so-called 966 study, which randomized 1,400 patients to either Xelox or FOLFOX plus minus Bevacizumab. Now, the initial data focusing on progression-free survival were positive, but the hazard ratio were far from what we saw with the IFL data. Instead of 0.54, we see 0.83. So minor benefit, which is actually even worse when we now separate these FOLFOX and Xelox patients out separately. In the initial analysis, there was really no benefit in terms of progression-free survival when Bevacizumab was added to FOLFOX. Now, why would I personally still use FOLFOX and Bevacizumab as one of my standard first-line therapies? Because of the analysis that actually was pre-planned and gave us a lot of indication about how we should actually utilize anti-VEGF therapy, highlighting the idea that duration of therapy matters. A pre-planned analysis looking at patients who were kept on therapy long and did not stop therapy before they had reached progression indicated when FOLFOX plus Bevacizumab is utilized in this fashion, then we see benefit. Then we see the separation of the curves, progression-free survival benefit, and this is really what matters. Now, we have new medical treatment options. We have new agents and treatment principles that are approved by FDA, which we'll talk about in the next couple of talks, with VEGF inhibition beyond progression, Bevacizumab. We have Aflibercept as a new molecule. We have a small molecule kinase inhibitor, Regorafenib. And we have several other agents under investigation, Ramucirumab and other kinase inhibitors. Now, we see kind of a puzzle piece here, or puzzle pieces all coming together with these different agents that are currently available for the treatment of metastatic colorectal cancer. And when we look for guidelines, how we treat, how should we utilize these agents in the algorithm of, let's say, our treatment sequence for metastatic colorectal cancer, we look for, let's say, published or consensus guidelines. And there are two major consensus guidelines out there which should kind of facilitate and simplify our treatment approach. The first is, as you can already see, a very complicated approach. The ESMO guidelines, you see a lot of ways how patients can move from line to line to line of therapy, depends on where they start from, what their clinical characteristics are. In the US, the NCCN guidelines are more important, and you also, the slide already shows here, this is still a very complicated algorithm with different ways how patients are characterized up front, move through these different lines of therapy. This is just one page of the comprehensive NCCN guidelines, the latest version. 3 additional pages with algorithms are listed in this setting. So there is a clear need for us to educate our investigators, our patients, our physicians, oncologists, how to best utilize all these new treatment options based on the standards of care that have been developed until 2012.
Okay, well, Axel, thank you very much. That was very interesting. Looking at that slide of the ESMO guidelines reminds me of the slide of the Tokyo subway system that's been used to show all the signaling pathways, and it's easy to see how people can get confused. But
these guidelines are supposed to simplify our approach and
we're going to straighten them
guidance. Yeah.
All right, so Jolene, bring us up to date on what has happened since Axel went through everything with agents targeting VEGF and the monoclonal antibodies that have been developed and the newer things that are coming down the line. So bring us up to date as to where we stand at this point.
Okay, Jim. Well, I think we have several new options to use at the anti-angiogenesis agents in metastatic colorectal cancer. We know that Bevacizumab, for instance, has activity in the first-line and second-line setting, and we had a suspicion that continuing Bevacizumab beyond progression would improve survival, but this was based on registry data and hadn't really been proved in a randomized clinical trial. We actually have that trial now in the TML study. This was presented last year at ASCO, and this study randomized patients who had previously received an oxaliplatin-based regimen plus Bevacizumab or an irinotecan-based regimen plus Bevacizumab. We were actually randomized to switch the chemotherapy backbone and then either continue the standard chemotherapy alone or continue chemotherapy with bevacizumab. Now, the primary endpoint of this trial was overall survival, with secondary endpoints being progression-free survival. I think we really need to pay particular attention to the exclusion criteria in this trial. Patients who had diagnosis of progressive disease greater than 3 months after the last bevacizumab administration were excluded, as well as patients who had progression-free within 3 months of the first-line therapy, and patients receiving less than 3 consecutive months of bevacizumab in the first-line setting. These were all excluded, indicating that patients with a little bit more aggressive disease up front that didn't respond to bevacizumab were not included in this trial. So here's the overall survival plot for the TML study. And it did favor that continuing bevacizumab into the second-line setting did show a 1.4-month improvement in overall survival. And this was significant when it was overall and when it was stratified for different factors such as the duration of bevacizumab use. In addition, it did improve progression-free survival on the order of a little over a month as well. So I think this is the first time that we have had randomized data to suggest that using bevacizumab beyond progression is beneficial for our patients. Now, the degree of benefit wasn't really in terms of response, and most of the patients' benefit was obtained by just disease stability, with the disease control rate being 68% in the bevacizumab-containing arm versus 54% in the chemotherapy alone arm. So we're not seeing big responses, mostly just stable disease in these patients. Now, the adverse events related to bevacizumab that we're very concerned about, hypertension, proteinuria, bleeding, and/or hemorrhage, were increased in the bevacizumab arm as expected, but the grade 3+ events were actually very small. So I think it's showing us that we can safely continue bevacizumab into the second-line setting. Now, the other area where bevacizumab is being used now is more focusing on the elderly patients. This has been an area of controversy, whether it's been safe to use bevacizumab in our patients 65, 70, or older. Now, the AVEX study, which was presented at ASCO GI this year, randomized patients who previously had untreated metastatic colorectal cancer, who were greater than 70 years and performance status 0 to 2. And patients were randomized to either receive capecitabine alone at a dose of 1,000 milligrams per meter squared BID, which is about 25% less than the standard dose, or capecitabine, same dose, and combined with bevacizumab. Now, again, I'd like people to pay attention to the exclusion criteria on this trial. So people who had had any prior anti-angiogenesis treatment were excluded, as well as people with significant cardiovascular disease, those on aspirin, and those on full-dose anticoagulation were also excluded. So it tells us it's a select group of older patients that were enrolled in this trial. Now, the progression-free survival curves are seen here, and did show a very remarkable improvement in the progression-free survival on the order of about 4 months for patients receiving the bevacizumab versus chemotherapy alone. Likewise, the overall survival was also improved, although this was not statistically significantly different. I think the several-month difference in overall survival is clinically relevant, and the overall survival benefit may have been lessened by second-line therapies that patients may have received on the trial. If you look at the overall survival is plus 20 months, and this is what we would expect approaching 2 years using the biologic patients for people with metastatic colorectal cancer. So I think even in this elderly population that didn't seem to be fit for oxaliplatin can have very good overall survival with the use of capecitabine and bevacizumab alone. Now, another way that people are using angiogenesis agents, or what has been tested, is in the OPTIMOX-3 trial, combining bevacizumab with the EGFR inhibitor erlotinib. Now, this has really not been standard practice since the results of the PACE trial as well as the CAIRO-2 study, which did show that dual inhibition with a vascular endothelial growth factor agent as well as the epidermal growth factor receptor inhibitor combined with chemotherapy actually showed a detriment for patients with the EGFR inhibitor. So the OPTIMOX-3 study randomized patients who had had first-line chemotherapy with either FOLFOX, XELOX, or FOLFIRI combined with bevacizumab, and then patients were randomized to receive either bevacizumab alone or bevacizumab combined with erlotinib, and this was continued until progressive disease. Now here is the progression-free survival curve, which did demonstrate a significant improvement in progression-free survival for the patients that received the combination of bevacizumab with erlotinib compared to those who received bevacizumab alone. And this progression-free survival benefit was significant whether it was looked at from the time when patients were randomized to the maintenance therapy versus the time from being registered on the study. Now, the overall survival for all patients was 25 months, which again is right in line with what we would expect for survival with metastatic colorectal cancer with modern therapies. We don't have overall survival benefit or data yet for the two arms, so it's hard to know whether this will become part of clinical practice, but it is very interesting results. Toxicities were an issue with this trial, with the erlotinib arm obviously having more issues with diarrhea and skin toxicity, which we would expect versus bevacizumab alone.
Jolene, I have one question about the DREAM trial. Was it stratified for KRAS mutation status, since they were using an EGFR targeted agent?
That's an excellent question. I don't know I don't think that that this was stratified for KRAS.
I wonder, that would be interesting to see if it made a difference. The curve didn't look like there was a subset separation.
Yeah,
but
so they did present data at ASCO GI about the different KRAS wild-type and KRAS mutant tumor separation. And they're interesting, there was no difference in outcome. The KRAS mutation, which was not stratified, as Jolene rightfully said, did not predict, it was not a negative predictor for efficacy here, which I think was interesting. It was only a poster presentation, so no big press release about this, but I think it's interesting.
Very good. Well, sorry to interrupt.
That's okay. So also now in targeting angiogenesis, we have new large molecule inhibitors. The first one that I'll talk about is Aflibercept, otherwise known as VEGF trap. And if we go back to the previous slide, we'll see VEGF trap actually is a protein that targets the ligands both of VEGF-B and VEGF-A. And so the VALOR study looked at patients who had failure of an oxaliplatin-based regimen, and they were randomized to either receive FOLFIRI with or without Aflibercept. 30% of the patients had bevacizumab previously, meaning so 70% did not have prior bevacizumab use. And here are the survival curves from the VALOR study. And what we can see is that overall survival and progression-free survival were both improved with the addition of Aflibercept to FOLFIRI. And we have this magic number of 1.4 months again for the overall survival benefit with Aflibercept. Now, the efficacy did not appear to rely on whether patients had prior bevacizumab or not. So if they did have prior bevacizumab, they still did achieve some benefit, although this was slightly attenuated in the overall survival. The response rates were quite interesting. So if patients had prior bevacizumab, they had an increased response rate, but without prior bevacizumab, the Aflibercept arm had a much higher response rate, 23% versus 12%, which is FOLFIRI alone. So I think the response rates, if it's needed to treat a patient in this setting that hadn't had prior bevacizumab use, I think Aflibercept would be a good option for that patient. Now, the one major concern that people have had with Aflibercept, and I think is the major reason why we have not seen a large uptake in the use of Aflibercept in the community, even though it is FDA approved now, is that there was significant adverse events, and actually adverse events that led to discontinuation of the study, with over a quarter of patients on the Aflibercept arm discontinuing treatment due to adverse events versus 12% in the FOLFIRI alone arm. And the side effects included diarrhea, neutropenia, stomatitis, and asthenic conditions, which we typically wouldn't see with FOLFIRI alone to this degree, and we typically wouldn't see if we had used bevacizumab in this setting as opposed to Aflibercept. So I think this is one reason why we're not seeing a lot of use of Aflibercept yet in the community. The other large molecule inhibitor that is being developed now is ramucirumab. And this is an antibody that targets the VEGFR2 receptor. And there's currently an ongoing phase 2b trial, which is randomizing patients in the second-line setting for metastatic colorectal cancer, KRAS wild type, to receive either cetuximab plus irinotecan or cetuximab, irinotecan, and ramucirumab. So we'll be able to see if this, if ramucirumab does add any benefit in terms of progression-free survival for these patients.
Very good. All right, Jolene, thanks. That was great. That really brought us up to date. Well, Scott, it's your turn. Targeting the tyrosine kinase domain of VEGFR has not met with a lot of success in the past. Is that going to change?
Well, I think we now clearly see evidence that it has, and it appears, as I'll share, to be really a function of how we use these agents. That, I think, really highlights some of the very interesting developments that we've seen in VEGF. And so what I'd like to do is to focus a bit on the small molecule inhibitors. And we use this term to predominantly mean the tyrosine kinase inhibitors. So instead of inhibiting ligands that bind to the receptor, instead focusing on inhibiting the receptors and the receptor's ability to signal. A consequence of this is that we are blocking signaling with a variety of different ligands and through a variety of subtly different pathways. Now, this is relevant based on some of our improved understanding of why bevacizumab may or may not work in certain patients. And it's become increasingly clear that this is a complex environment that involves more than just the VEGF-A ligand. And this slide attempts to try to piece together some of our understanding about some of the different pieces in the tumor biology. And what I'd like to do is to focus on a few of these to highlight some general concepts that are relevant in not only our current recent developments, but where the field of angiogenesis is going. One of these factors is the fibroblast growth factor, and this is a factor secreted from the tumor that may work on the endothelial cells. And this had some very interesting data that suggest that that basic fibroblast growth factor can actually restore angiogenesis despite inhibition with VEGF-A. And so this is some early, very exciting work that had suggested that in patients, in preclinical studies, that when you inhibit VEGF-A through inhibiting the VEGF receptor, that you can initially get some benefit, but then that's followed by the development of progressive disease. And that disease progression then can be blocked by the dual inhibition of FGF, basic fibroblast factor, and VEGF. So this has led to recently several studies, one of which I'll share with you is the Brivenib study. Brivenib is a small molecule tyrosine kinase inhibitor that inhibits both the VEGF receptor but also the FGF receptor. And this was a phase 3 study, the CO20 study, that demonstrated that in patients that had failed irinotecan, failed oxaliplatin, that may have had other prior inhibition for VEGF, randomized to cetuximab and placebo or cetuximab and Brivenib, with this idea that that the combination of a VEGF inhibition with the FGF inhibition and in the setting of cetuximab use may provide some benefit. Now this was instructive because although the study was negative, its primary endpoint was overall survival, and as you can see from this, this figure, overall survival differences were not seen. There were differences in progression-free survival, suggesting that there was some evidence of efficacy in this subset with a hazard ratio of 0.7. But did not meet the pre-specified endpoints. So although this showed efficacy, it came at the cost of toxicity. And so this study demonstrated that Brivenib was a difficult agent to administer, had higher rates of dose reductions, missed doses, and a shorter time to a decline in the quality of life. And this is a relevant point in our development of these agents, as we recognize that adding in these additional targets into these combined inhibitions can indeed worsen quality of life, worsen toxicity, and may have an impact on efficacy, even though the fundamental biology may be relevant. There are, as I mentioned, the Brivenib study, and the development has been halted for this agent, but there are other agents being developed, such as you see here with the BIBF compound, and this is a study in the first-line setting in FOLFOX, as well as a second-line randomized study as well. Again, looking at the concept, does FGFR inhibition make sense? And so we look forward to some of these results. With that, we also recognize, back to our proposed mechanism slide, that there is more than just one or two ligands that may play a role. And the other that comes up is these other angiogenic factors, such as platelet-derived growth factor and placental growth factor, that can be secreted into the microenvironment and can cause and result in restoration of angiogenesis. This recognition is important as we think about one of the success stories in the past year, which is Regorafenib. It's an oral tyrosine kinase inhibitor that hits multiple different kinases, and you can on the slide see the list of agents, many of which are relevant in angiogenesis. And this is an agent that was then studied in the CORRECT study. This was a multi-center randomized international study where patients were randomized 2-to-1 to Regorafenib or placebo combined with best supportive care, looking at a primary endpoint of overall survival. Now, this study, unlike many of the other tyrosine kinase inhibitor studies, was done as a single agent, and I think that allowed a good dose of this drug to be administered with reasonable side effects. And this is in contrast perhaps to some of the earlier tyrosine kinase inhibitors that were developed with chemotherapy. Now, this was a positive study and demonstrated improved overall survival, its primary endpoint, hazard ratio of 0.77. The median here of 1.4 months improvement in overall survival. Now, this doesn't perhaps capture some very interesting findings that are seen in the progression-free survival curve. Here we saw a greater benefit, hazard ratio of approximately 0.5. Very substantial differences in the curve. But as you see, and as we talked about with KRAS, there's a narrowing of the curves early on prior to separation later, suggesting that there's a subset of patients that may be deriving the majority of the benefit. And I think this is what's driving a lot of the excitement in this agent currently. Now, I mentioned there are side effects with it, and these are not trivial but are manageable. The big ones are hand, foot, skin reactions, fatigue, hypertension, some of these related to the anti-VEGF targets, but also very akin to what's seen with Regorafenib therapy as well. There were higher rates of treatment discontinuation, but still a very manageable 8%. But I think there are some lessons that can be learned from Regorafenib and clinical utility. How do we actually use this in the clinic? And although this is an agent that has a labeled dose of 160 milligrams daily, in clinical practice, a lot of us are following the Regorafenib model, starting at a lower level and escalating in several weeks as patients tolerate to the full dose. We also recognize that there is benefit in being preemptive, and that's one of the lessons we've learned both from EGFR inhibitors and also was seen with Regorafenib in HCC. That specifically, if we use urea-based creams, 10% urea 3 times a day, from the start, before development of symptoms, in this randomized study of Regorafenib, that has seen a 30% reduction in grade 2-3 hand-foot syndrome. So this may be something that can be applied to the Regorafenib. Now, back to our model of Bevacizumab resistance. We know that there is a large number of potential other agents and other targets. And the area of angiogenesis research in the future is alive and well. And really thinking about both these targets that are on here as well as some that aren't, how we can do a better job of moving forward. And there are a variety of agents in trial, and I list a few of these on this slide, including targeting angiopoietins, targeting the HGF, c-Met axis, the Notch and DLL ligands as well. So a variety of different approaches that are being used to really take some of the benefits we've seen with anti-angiogenesis therapy and move this forward. Now, in the past year, as has been noted, we see a large change in the types of agents that we have available. And this summarizes an approach that can be proposed to really optimize the treatment of unresectable metastatic colorectal cancer. And the concept of starting with chemotherapy that includes Bevacizumab and a doublet in most patients, continuing Bevacizumab for those patients who are having some benefit and then develop some slow progression, with the idea of saving EGFR inhibitor to a later line therapy followed by Regorafenib. But recognizing that there are some patients where the disease is more rapidly progressing, or perhaps adding the EGFR inhibitor in second line, or using Aflibercept based on some of the data that was just presented, followed by Regorafenib may be an appropriate model. But again, we see flexibility in how we can move forward and opportunities for personalizing care. So in summary, the prognosis of colorectal cancer patients has substantially improved over the last 10 years. And this improvement is linked to the availability of multiple agents, utilizing all available agents over multiple lines of therapy. And these combination regimens are really now the standard of care for first and second line therapy. Now, these major advances in the management have been achieved by prolonged VEGF inhibition. And I think this is the story that we're seeing with Aflibercept, Bevacizumab beyond progression, and Regorafenib. and that future treatment breakthroughs will likely require better optimization of anti-angiogenic therapy, but also understanding which patients are really benefiting, as is suggested, for example, by the Regorafenib story. So we can update our advances in the treatment of stage 4 colorectal cancer slide now to add 3 different drugs or concepts on both Aflibercept, Regorafenib, and Bevacizumab beyond progression, with the recognition that now we appear to have broken through that 2-year ceiling in overall survival with really 2.5 years, and hopefully as we see more of these regimens move into standard of care, even beyond as we move forward.
Very good. Scott, thanks so much. Well, let's conclude this session, and we will be back with session 2, and we're going to look at a number of clinical scenarios and see how our expert panel would manage patients in first line, second line with after a good response and slow progression, second line after a rapid progression, and what to do in third line. So stick with us. There's much more to come. Thanks a lot.